All right, so my talk today will be indications for surgery and shoulder instability. And I have, you can see my disclosures on the website. I am going to disclose, however, that I'm a shoulder preservationist. I love the labrum, the capsule, the bone. I like to prevent osteoarthritis, especially in the first-time dislocator. Well, that's new. ACL injuries, we just talked about. And what's crazy about that is that how is it that all of a sudden we believe that we shouldn't reestablish stability. If I have a both bone forearm fracture, which is going on in the trauma section, again, why aren't we reestablishing stability? Shoulder dislocations. Now I'm going to have an actual discussion that we don't need to reestablish this. Really? So Chuck, good luck with this discussion. So I can tell you this. Who rarely needs surgery? I believe that people with collagen disorders, atraumatic instability, volitional instability, and psychological disorders, you stay away from those folks. Easy decision. Who needs surgery after the first-time dislocation? And patient selection is the key. Again, this gentleman on the left side has a totally different shoulder dislocation the first time than the patient on the right. So who is likely to have a recurrence after a dislocation? Well, there have been two meta-analyses that have been out there. And what do they show? They show that age is probably the highest risk factor. So when I'm deciding to try to treat somebody surgically, age becomes very important. Hyperlaxity becomes important, contact sports, and also bone loss. And I think that what we've really learned over the last decade is that bone loss plays an enormous role. So what do we know? Bob Arciero did a study of West Point athletes, looked at 63 athletes acutely, arthroscopically, and found that there was pretty significant damage in everybody's shoulder when they dislocate. 61 patients had a Bankart lesion, one had a capsular tear, and there was bone problems associated with all of this. So early intervention for first dislocations, reasons why: first, less risk of bony deficiencies, less risk of capsular elongation, less risk of recurrence, if indeed you get to them right away. And this has been shown by Kirkley in 1999. Delaying surgery, recurrent dislocations, what are the risks? Well, the risks really are recurrent dislocations can affect surgical success. Many studies compare one dislocation versus greater than one, and they show that when you have greater than one dislocation, which would happen if you treated this in a conservative fashion, you increase your bone loss. Therefore, you have a higher likelihood of failure afterwards. And again, I'm going to talk a little bit about the bone loss later on, because that's really where we've changed the ways with which we treat these athletes. So if you actually look at the studies, it has been recommended that 2 to 3 is the magical number. However, in my opinion, the first time is the correct time based upon your patient selection. And here in a recent article in 2019, it shows that if you dislocate your bone once, you have a 6.8% bone loss. When you have a recurrent dislocator in this study, it went up to 22% bone loss. So be a preservationist and prevent the bone loss and the arthritic change by fixing them the first time. And let's talk a little bit about this bone loss, because this has been the greatest change in my practice. And in an understanding of what's called the glenoid tract, we owe an awful lot to Dr. Itoy, as well as Dr. Burkhead in Texas, about the contact area between the glenoid and the humeral head. In a healthy shoulder, the glenoid tract, the amount of glenoid with which it contracts the humeral head is 84%. An on-track lesion is where they, if indeed they've had a dislocation and they have bone loss in the Hill-Sachs area, the Hill-Sachs stays within the glenoid tract. An off-track lesion is one with which the Hill-Sachs is larger than the glenoid width or is more medial. As a result of that, you begin to increase the rate of instability and failure of surgical repairs. And here are the recommendations. We'll get back to that a little bit later on, but it's all based upon these glenoid defects. So risk factors for failures, we talked about. Patient selection is by far the most important thing, but age, multidirectional instability, bone loss, poor tissue quality, all of these things can lead to increased risk of failure. So in my practice, who gets an arthroscopic Bankart? Well, you've already heard this. I believe that the acute Bankart is the golden opportunity to provide fixation, restore anatomy and function, and provides really, quite honestly, predictable improved outcomes. I'll bet you all the therapists in the audience know that if you have a non-apprehensive shoulder and you're doing your physical therapy, you can do an awful lot with that periscapular and rotator cuff platform. The largest risk factor for failure arthroscopically, again, is patient selection. So therefore, if you're going to do an arthroscopic Bankart, make sure that the bone loss is minimal, that the Hill-Sachs lesion is minimal, that it's an on-track lesion. And again, there are certain athletes, like throwing athletes, that you may want to consider doing that type of Bankart procedure arthroscopically. Who gets an arthroscopy, what's called a remplissage, where we bring in the lower portion of the supraspinatus and infraspinatus into the Hill-Sachs defect. These patients, again, are based upon this bone loss categories. And again, if you have an off-track lesion with minimal glenoid bone defect, you may want to add that extra remplissage repair. Who gets an open Bankart? Believe it or not, in my practice, my contact athletes, my wrestlers, I actually do a large portion of my patients open because I can manage the capsular shift and I can do a good repair on them. So these are people with minimal bone loss that are high collision athletes that maybe have had a failed previous repair. If they come in with greater than 5 dislocations, I'm usually moving my procedure to an open type of procedure. Again, age of athlete and demand on the shoulder becomes very, very important. Who gets a Latarjet? I truly, it may be because I functionally can't do it, but I like the open Latarjet procedure. It's a procedure with which if the bone loss is greater than that, 20, 25%, failed previous surgery, has poor capsular laxity, has had a great number of dislocations. I'm now thinking about a bony augmentation procedure to have that. The problem is that if you fail your Bankart repair, it's not that bad. I've got other options. If I fail my Latarjet, I've got big troubles. So just remember, if you're going to do that Latarjet procedure, do it well and make sure it's in the right spot. The throwing athlete is a very unique athlete. You have to get range of motion back in that dominant arm. However, is the throwing athlete willing to accept a risk of recurrence for the ability to play? And it's always a difficult situation to fix a throwing shoulder. The contact athlete, again, is a unique animal. There's a high failure rate of arthroscopic techniques unless it's the perfect storm. So therefore, I move towards that open Bankart procedure if I can. So in the end, remember, it's not just the shoulder dislocations. You need to be aware of the risks. You need to be aware of the risks of both treating it non-operatively and treating it operatively. So our goal is to prevent the failed treatment as much as possible. So what do instability patients want? They want to remove the instability. They want a better quality of life and return to athletics. They want a bumper-to-bumper warranty. And you've got to ask yourself, is conservative management really giving them that bumper-to-bumper warranty that it won't come out again, that it is long-lasting and durable? Timing depends on the individual features. In my 30 years of level 5 evidence, again, my 30 years of level 5 evidence is that I like to fix them after their first event. Again, success is all about selection, either rehabbing them or operating them. The success is based upon selection. So I thank you very much, and I can't wait to hear from my counterparts.